Am I audible? Right. So far, thank you. So we come to this session on public, private, and most importantly, people partnership. So I think whatever we heard in the morning, with probably 1.2 billion people, I think neither the private sector nor the public sector can provide healthcare. It's very important that they both collaborate. And here we get the second part of it, and which we added, that it's important to have the people involved. So before we even start, I want to actually do a question based on to the audience. And the question is healthcare in India ready for public-private partnership? And I hope all of you have the voting buttons. So if you say yes, it's A, otherwise it's B. Can we have the question on board? So I think while we'll discuss all the issues about how do you provide healthcare to the population, what's happening in public-private, but I think the first thing is, are we ready for public-private partnership? Is there a will from the government side? Is there a will from the private side?
There you get the answer. Yes.
Yeah, but still, quite a few people haven't got the button, so it could be 50-50.
Yes, it's 59.
Right, I think we'll just wait for a couple of seconds, and then I'll start the panel discussion.
So it says true, false.
59 is yes, I guess.
Good, at least we don't have a hung parliament here. It's quite clear. Right. So while that's going, let me start off with the most important, that's the public part of it. So my first question is to Dr. Vishwas Mehta. I think for this whole public-private partnership to take place, one of the most important thing is what is the role of the government going ahead? Over the last 5 years, we've had conflicting signals. I think the government's moving away from becoming a provider to becoming a payer. That's where the whole insurance scheme comes in. But at the same time, it's strengthening its healthcare systems. At the same time, various states are, doing things which may be contrary to what the central government. So is there a uniform policy of where will the government, what does the government want to do, and where do you see it in the next 5 years?
As far as government is concerned, I think the answer is yes. We would like to have the public-private partnership. How do we do it? Answers are many, many of them. We have successful models in various places, successful experiments and pilots being run in various states. But we don't still have a uniform strategy where we can say that, yes, this is the model which perhaps will work as far as providing healthcare to 1.2 billion people is concerned. I just want to point out that we have to understand that being a huge country, what works in one state does not work in the other state. Population of UP is equal to Brazil. That of Kerala, which is a small, tiny state in south, is equal to that of Canada. So what works in Kerala may not work in UP. What works in UP may not work in Northeast. So you cannot really say that here is one model which can be replicated all over the country. Now, I would also like to say that the government's presence is basically to ensure that the 750 million people living in 650,000 villages are provided affordable health care. And that is where private sector is largely missing. Private sector is mostly confined to 5,000 towns and cities where 30% of the population of India lives. So we have to perhaps look at models where it goes beyond those 5,000 towns and cities. And there are such models available which we discussed during the course of.
Right. But going ahead, do you see that the government's going to be strong on the provision of care, or is the provision of care going to be confined more to primary care and getting the private sector more involved in the tertiary care sector? Or do you see the government also continuing in those two areas of secondary and tertiary care?
I think primary health care is one area where private entrepreneurship will be difficult. We have private sector starting from one-man clinic to multi-speciality hospitals all over the country. So we have about 148,000 sub-centers which look after about population of 5,000. They are not supposed to be managed by doctors. We have about 25,000 primary health centers in the country. They are supposed to be looked after by at least 1 or 2 doctors. Most of them do not have doctors. We have about 3,500 community health centers where minor procedures and etc. are carried out, but we don't have full contingent of doctors. So I think the only area which I personally feel, having been the health secretary of Kerala, I find one area which can work very successfully is the area of diagnostic services. The reason I say is that because out of 644 districts in India, we have 422 districts which do not have even a single medical college. And if you look at the geographical distribution of medical colleges, they are all confined to the south and the west. 65% of all medical colleges are in the south and the west, whereas the country needs them in the north and northeast and northwest perhaps, where there are no doctors, there are no facilities. So diagnostic services perhaps beginning from the district hospitals, where we can provide ultrasound machines, you can have x-rays, we can have CT scans, you can have diagnostic labs. Those areas can, I personally feel, can work very well in public-private partnership.
Thank you. So Krishna, I think that takes us to the next point that, if we were to look at success stories in India, I think it's happened really on the diagnostic side, both on the radio diagnostic and the lab diagnostic. And I think the impact it's making is very, very different because, having access to even a simple X-ray or a simple blood test tells you more about our health care of our country than anything else. So a lot of these diagnostic PPPs have actually worked. So what's been your experience, and going ahead, what do you think could really catalyze this growth?
Sure. I think Dr. Mehta makes a very interesting point to start with, which is to put the diagnostic services in context and PPPs in healthcare in context. We've had about $130 billion or 700,000 crores of investment, which has gone into PPPs in general in India, right? 90% of that has gone into the core sector of PPP, right? The total investment in private PPPs in healthcare has really been to the order of about 1,850 crores as a ballpark, right? Which is about $0.3 billion out of the $130 billion that has gone in, right? So clearly, overall social sector investment in PPPs has been lagging, if you will, rather than leading in public-private partnerships overall. Within that investment of 1,850 crores, roughly about 60% of that investment has actually gone in diagnostics so far. And much of that has really been clustered around 9 states of India. Again, to his point, exactly predominantly along the south and west of India, not enough in the north and east of India. It's not to say that there haven't been proposals in the north and east of India. There have been several proposals from Delhi, from UP, from Bihar, going all the way to the east and northeast of India. But several of them have kind of, if you will, not had the political will to kind of go through, because at the end of the day, it is still a state subject. There have been a few key successes in the south and west of India. So if you take the states of Gujarat, Maharashtra, including Rajasthan, which technically we categorize it as the north, you can decide on where it falls, through to Karnataka and Andhra Pradesh. If you take some of these states which have moved forward, and we have something like a 6 to 7 year track record of seeing the progress on these public-private partnerships, a few key things have held true, which has contributed to the relative success. And I would still call it a relative success. The first one has really been that the nature of diagnostics is such that you invest, it takes about 5 years really to break even in any investment in diagnostics, especially as you go in for the higher end investment. And it takes the latter half of the 10 years, which is the second 5 years really, for you to recover your investment. So it is capital intensive in nature, and it takes time for you to recover your funding for the most part. The reliance on CGHS, which is an accepted scheme, as the rates, determining the rates of payment, has brought clarity to reimbursement rates, and therefore, from a private investor standpoint, a private investor is primarily looking at 2 or 3 key things. One is, is there clarity on the rates? And second, is there going to be stability of policy for 10 years that it's not going to get yanked after I have put in the investment, right? The government interest is clearly understood, which is you want to create access and quality of care, but also ensure affordability, which through the CGHS, as well as a certain fixed percentage of patients getting covered free of charge, broadly that has been covered. Based on the last 6 years that we've seen in the diagnostic services space, I think it's fair to say, at the risk of putting out a rough figure, roughly 80% of the projects are showing very good progress in terms of both creating access to care, ensuring affordability, as in it is CGHS rates or lower rates at which these projects have been done. The third has been, it has ensured a reasonable return, very clearly well below where it needs to be. But what it has not seen success on has been to bring in most of the leading players from healthcare in actively to participate in the process. So clearly, in my view, I would rate it as pilots have been done. I think there is a lot more to be done if you need to scale it up.
Great, a good beginning, but miles to go. Rajan, I'd like to bring you in at this point. I think this whole PPP story catalyzes, I think we'll not have problem with access to capital. We won't have problem with access to technology. I think, again, the roadblock will probably be human resources. So one of the areas where we've not seen very much PPP is in the whole area of medical education. And you were telling me you've got experience on that side. Because I think that's going to be the biggest roadblock as both the private and the public sector get together. But where are the doctors to do it?
Let me try and put that into perspective because it actually addresses 2 issues. I completely agree with... can you hear me now? Oh, great. Is that okay? Yeah. I'm a soft-spoken person. I would agree with Dr. Mehta and with KK. There have been relative successes in the area of diagnostics, imaging diagnostics, and maybe in terms of dialysis, and to some extent, maybe even in terms of primary care. But when we talk in terms of PPPs, typically what happens is we talk in terms of managing of hospitals. And these would be typically district hospitals. And I think that's where everyone comes to a roadblock because what the government wants and what the private sector wants in terms of addressing a PPP relationship for running a government hospital or a district hospital, the objectives don't match. And let me try and explain that. This morning, Dr. Ahluwalia talked about how the government is looking at inviting private sector to run, to use the district hospitals as for medical schools. And I think I want to put my argument on that foundation because I think that is actually something that we should look at and would work fairly successfully. If you look at district hospitals and the government's need to improve the operations at the district hospitals and the private sector being invited to run them, the government is talking in terms of providing subsidized care. And typically, when you look at the drafts that come out of the government is talking in terms of anywhere between 20% to 40% being subsidized. Whereas when you look at the private sector is really talking in terms of getting a return on that investment. So at no point of time would it be very easy for the meeting of the minds of these 2 stakeholders in this. Now, if you move that aside and then say, okay, why don't we look at private-public partnerships in the area of matching, where we can match education and healthcare? I think there could be a meeting of the minds. And let me explain why. If you look at any of the teaching hospitals, 95% of the teaching hospitals are using the medical schools are using the teaching hospitals for clinical teaching. They're talking in terms of patients coming there and the patients essentially being the subject for clinical teaching of the students. And most of the teaching hospitals are providing highly subsidized care. So if you then look at it, that here you have a private medical school which is looking at running a teaching hospital on a subsidized basis, then it actually meets with the objective of the government, where the government says, okay, this is exactly what I want, where I want the patients to be provided care at a subsidized level. So if that is fine, then I see, rather than inviting the private providers of healthcare to manage the to manage the district hospitals, invite the private educational providers to look at taking over the teaching hospitals. And I think there's a win-win here for all of us. And this actually has been fairly successfully done for the last 30 years by Manipal University in the town of Mangalore, where we actually have taken 2 of the government hospitals as part of the medical school. What happens here is that the hospital is provided subsidized care. The university or the medical school is giving the government a fee for every student that it intakes. And it also has the obligation to look after the infrastructure in the government hospital. And the faculty, which is part of the private medical school, is there to provide the care for the people who come into this hospital. And I think if you look at all of this, every factor that is required to be addressed has been addressed. And therefore, I do believe that if we turn this around and say that we should look at district hospitals being run as parts of medical schools, I think you would be able to, one, cater to the people who live around these district hospitals. 2, you would be able to provide highly subsidized care. And 3, as part of it, you will also address the issue of creating skills within the medical education sector. But there are challenges here, and the challenges is what we really need to address. The challenge is that the education, as Dr. Montek Singh Ahluwalia said this morning, is a central subject, medical education. But the delivery of care and the district hospitals is a state subject. And I think this is something where we need to come together and then look at how we can address and therefore resolve the issues with respect to PPPs.
Thank you. Paul, Dr. Montek Singh Ahluwalia in the morning, alluded to this whole provision of universal health care. And typically the government's looking at that as a large component. Now that requires the integration of care. The PPPs cannot be siloed. You cannot have PPPs in primary, secondary, and tertiary, because you need one provider to look after healthcare, whose business should be keeping people healthy and out of hospitals. So you were telling me about a model in Spain which has really worked. So what are the learnings from that model, and how do you think that could be replicated in India?
Sure. So, I'll maybe illustrate it with a couple of examples, actually, and you can see some of the different ways that different governments have gone about trying to solve this particular issue. So, the project in Spain that you referred to has been written about extensively now. It's called Alzira. It's a part of the region of Valencia. And there and actually what I'll do is I'll take you back to the very outset of that project, because it had to be restructured because it didn't work the first time around. So, and this is not commonly talked about, but essentially back in, I think the 1990s, the regional government of Valencia let a contract to the private sector to both build a new facility and to provide hospital services to this catchment population of about 250,000 people. And in return, the Valencian regional government would pay the operator a flat fee for every member of that population. So I'll make up the numbers, but let's say it was 100 euros, so it would give them 100 euros times 250,000. And with that money, it had to provide all secondary and tertiary care for that population, however it decided to do that. However, at this stage, when it first structured the project didn't include primary care, so it was just secondary and tertiary. And so what happened was that the primary care physicians, who were still public employees and were the gatekeepers to the hospital care, were basically just sending everybody into hospital because they saw this as a cheap alternative. Why provide the care for themselves if they can just send everybody into this hospital, and the hospital then has to somehow provide treatment for all of these people, regardless of whether the hospital setting is the most appropriate place or not. And not surprisingly, the project was failing. And so the government and the operator sat down and they looked at why the project was failing, and very quickly determined that actually it was because the operator couldn't control the gatekeeper function that the project was failing. And so the project was restructured and relet. And so now you had the same operator providing primary care, secondary care, and tertiary care services for that same population for the same payment. But now, of course, they can control where and how they treat that population. So they can invest in wellness services, they can invest in primary care services, rather than having to see everybody in hospital. And this has worked quite well in Valencia for a number of reasons. One is that the government of Valencia already had clearly a number of other public hospitals that were functioning on the same basis, so they were also being paid on the capitation basis. And so they could apply that same capitation method to this private operator. And it already was measuring quality outcomes for the public hospitals, and therefore it could apply those same quality outcomes to the private operator. And what's happened over time is that actually the reason people see it as a success is that this private operator now can control how best to treat that population. It has the right mix of incentives to treat them in the best setting, and it is able to measure or to provide the same level of quality, if not better, than the rest of the public hospitals. One nuance in the system that I think is quite interesting in terms of providing the right incentives is that if anybody from that region goes outside of the region for treatment, and they can, the population can choose wherever they want to go within the region. So if they go out of their catchment area to another neighbouring hospital, the operator now has to pay to that neighbouring hospital 100% of the cost of the treatment. And if it attracts people from outside of its district to come to its hospital, then it receives 80% of the value of that treatment from the neighbouring hospital. So now the incentives are on the operator to make sure that it's not just providing good quality healthcare, but actually convincing the population that it is doing so, because it needs to retain their attendance in the hospital. And so the measures now that we've seen are certainly that the quality is as good, if not better, than public hospitals. And in terms of efficiency, they're providing the same types of service with an efficiency saving of 25% when compared to the public hospitals. So that's one example of how the integrated model is developed there. If you look at perhaps another example that has applied a slightly different mechanism, which is a project that IFC advised on in Africa. This is the National Referral Hospital in Lesotho, where some years ago the government decided it needed to rebuild its National Referral Hospital in the capital of Maseru. It realized that it actually didn't really have the capacity not just to rebuild it, but also to then run and provide quality clinical services. And it decided to undertake a PPP to do this. The approach here was different from Valencia because the circumstances were different. So here you had a government that had the right motivation to do something new and wanted to do something innovative, but didn't really have any of the infrastructure in place to be able to roll out a model like in Valencia. So there was little or no clinical data available. There was no real understanding of the full cost of providing clinical services, and there was no way to there was no gatekeeping function as such. So patients could decide themselves whether to go straight to hospital or go and see a primary care doctor around the capital or indeed around the country. So in this case, the structure was that the government basically said to the private sector, okay, I have a given budget, I have this much money, and now what I want from you is for you to, through a bidding process, tell me what level of service you can provide for that budget, how many inpatients you can treat, how many outpatients you can treat, and then we'll monitor that on an ongoing basis, and we'll agree a mechanism so that if you see more than the allocated amount, you get paid extra, and if you see less, there's some sort of rebate. And that project, and again, has had some very, and in fact, the World Bank has just conducted an evaluation program on that project and has published a report, which has some very interesting findings. And from a clinical point of view, frankly, the quality outcomes is, I mean, just beyond anything the public sector could have imagined. So we have something like a 41% improvement in mortality rates in the hospital compared to the previous hospital. We now have a situation where pretty much any neonatal birth beforehand had a very little chance of survival because there was no neonatal intensive care. Now something like 80% of neonatal births survive and leave hospital in healthy conditions. So it's proving to be delivering some very, very good quality indicators in terms of healthcare. It has some challenges, however, which is, again, you know, when you compare some of the models from around the world, it's always helpful to understand what the challenges have been and why the structure itself may have led to some of those challenges. And the challenges here are that basically the hospital has been overwhelmed with demand. And it's been overwhelmed with demand because it's seen as this sort of oasis of high quality, not just in terms of buildings, but in terms of healthcare provision. In fact, I was in Lesotho about 4 weeks ago and had the privilege of touring this facility, and I was amazed. I mean, I've worked on projects in pretty much all over the world. I've worked in developed economies and seen, and worked on some of the biggest teaching hospitals in Europe, for instance. But I was blown away by this hospital in terms of both of the quality, but also the level of organisation evident in the way that was being run. But as I say, the problem has been because they've been overwhelmed, and they've been overwhelmed because the government doesn't have any national referral system in place. So everybody that feels ill will travel from wherever they are in the country, and this is a small country of 1.5 million people. They will travel to the capital and they will go and wait from dawn till dark to be seen in this hospital because they believe that's where they receive the best quality. And of course now the challenge for government is how to deal with the issue of referrals and how to deal with the issue of bringing the rest of its healthcare system up to the same sort of standard as this particular place.
Thanks, Paul. I think an excellent example of if you get the incentive right, how the outcomes can really improve. I'll come back to you, Dr. Mehta. I think we've all been talking about the traditional mold of access to healthcare. So we've been talking about the physical access. Can I have a doctor next to me? Can I have a clinic? Can I have a hospital? That's growing, but growing very slowly. Even where we have the infrastructure, it's probably not used. We've talked about the financial access, which I think the government's really been successful. So close to 300 people now have financial access to healthcare through the Rashtriya Swasthya Bima Yojana. But the third part about the technological ability to have access and have healthcare 24/7, which is what everyone's talking about in terms of both telemedicine and mHealth. So I think the government can play a great role in that. So what do you see as the government facilitating, both from a regulatory point to make this happen? Because it's very clear that the first two accesses will grow slowly and it'll take decades before we can provide for everyone in India to have healthcare.
You're absolutely right. Actually, I am also looking after the medical education in the country. So I'm aware of what he's speaking about, where it's going to work and where it's difficult to work. You see, medical education in the country is essentially following the old British model, where it's hospital-centric and urban-centric. Even if you pick up medical students from rural areas and train them into medical colleges, they are not going to go back into rural areas, because we are creating doctors not for rural areas. We are creating doctors only for urban population. Then actually, MBBS graduate, if you look at them, if you post them in a PHC, what will he do? Actually, he is not trained to handle that kind of patient care. So even if you do them forcibly also, which we tried, MCI regulation recently made it mandatory for all the MBBS graduates to have 1 year compulsory rural posting before going for PG, and there was a lot of resistance on that. Some on fair grounds, some on flimsy grounds. But we have to look at this. Has technology been used in medical education? I'm sorry, it's not been used. We still follow the same old textbook models, which unfortunately has to change. And that's why MCI regulations keep saying maximum strength of a medical college should not be 100, 150, 250. If you look at the country, we have 387 medical colleges, which is the largest in the world. And we produce how many? 50,000 graduates. Why is it so? Because the number of medical colleges with 250 seats is only 7. Only 7 of them are 250 seats. So what about the rest of them? Most of the medical colleges are in the range of 100, 150, and some of them were 50 and all that. So it has to be viable for people to invest money into that. The quality standards cannot be compromised. Now, telemedicine, for example, I remember some of the states have done exceedingly well. But then you see, you look at the public health facilities. In medical colleges, if you see, how much time a doctor spends with a patient? 30 seconds, 1 minute maximum. The referral systems have collapsed in many places. I have not understood why should normal deliveries happen in medical colleges. And yet it happens. And there's no way in public health facilities you can say no to a patient who comes to you, and you can say that there are better facilities just 1 kilometer away, please go there. This is a referral hospital, come only for specialized health care. It's not going to happen in government setup. So doctors are not going to sit before those machines and going to give advice to others saying that, this is how we should do it. We did it very successfully in Kerala for Regional Cancer Center. Because the Kerala, if you look at the topography of that, it's a longish state. The regional cancer center is in the south. So we developed outreach clinics in the Kannur and Cochin areas so that the patients after surgery for follow-up treatment need not come back. They could be consulted on telemedicine, and only if something abnormal was found, they could travel 500 or 1,000 kilometers back to the regional cancer center. I think M-Health is going to work, because here doctor is not going to sit. Another thing is the regulatory part of it. If I give advice on the telemedicine, is it valid? I'm afraid it's not. There's no Telemedicine Act of India. If you ask me strictly, the prescriptions given on that, unless it is transcribed or unless it's recorded, it's not a valid prescription. So most of the doctors will ask these questions when you refer them for advice. But there is a great scope of this. I think technology should be used. We should use virtual classrooms. We should, it's not possible for 50 students to go and see the surgeries in the operation theaters. Why can't we use virtual classrooms where these, through optic fiber and the telemedicine network, you can show it in the classrooms, the minutest details. It is possible. We have started a national knowledge network. We have started optical fiber network in this country. And we have also started a national medical college network. And Apollos have done exceedingly well. In fact, I find they have got a very good telemedicine network. Is there any synergy possible? Certainly, yes. It's possible for technology to change the way we look at it. But for that, unfortunately, or fortunately, our regulators, principal regulators, the Medical Council of India, and not only them, the Nursing Council, the Pharmacy Council, as well as Dental Council of India, all 4 of them whom I deal with, are unfortunately not yet prepared with. Maybe with time they will change. They have to change.
I'm sure they will, because we pride ourselves as an information technology superpower, but we just don't use it in possibly the sector where it can have the greatest impact. Krishna, one thing we spoke about, so we've talked about PPPs in healthcare. Now clearly there's a learning from the other sectors. There have been a lot of sectors in India where PPP has been successful. So it's not that we need to reinvent the wheel. Of course, healthcare PPPs, they say, are very different. So it's like you build a road, and well, you've built the road, then you just keep collecting the toll. But you build a hospital, that's where the business starts, because then that's when the patients start walking in. While these whole differences are there, what do you think could be the 2 or 3 things which the government should address, which are really structural roadblocks to make this PPP in healthcare happen?
Sure. I think you mentioned one very good starting point, which is the example of roads in the country. About 60% of all PPPs which have happened in India have been in roads, right? So there's what started off with really defining the framework as of, if I remember right, about 1998 is when we defined the framework. And we had a master agreement, a concession agreement, which was developed for roads back in 1998 or 2000, if I recall correctly. Which has since taken root, and we've seen significant amount of progress happening in roads. I think Dr. Mehta and us, we were sitting and having a chat before we walked in, and I think the starting point for debottlenecking PPPs in healthcare, I think starts with both the government as well as representatives of the private sector sitting together and addressing a trust deficit if at all it exists, right? Quite naturally, there are going to be apprehensions on the government side about, will affordability of care be ensured and will access to care and quality of care be ensured, right? And obviously, there is a private sector apprehension of whether there is going to be stability of policy and is there going to be at least a fair return that's going to be available, right? So the starting point, which I know Rajan, myself, yourself, and several others sitting here are members of Nat Health that we've created as a body, is really for us to be able to sit down with the Ministry of Health, and many of them are clearly very progressive about this, to first start with a conversation about, is there a trust deficit, and really what are the apprehensions from the government side that the private sector can do to be able to earn your trust, if you will. That's, I think, pretty much if there is that conversation which happens, really everything else is how can you go about sorting those out? To your question on specific things that have enabled the road sector or airports, for example, I think the development of a master concessionaire agreement as a standard regulatory framework for roads has really helped. Because please do understand that healthcare is similar to roads, although not as capital intensive as roads. Healthcare too, especially at the technology end of healthcare, is very capital intensive, right? I mean, our payback terms are, if not as long as roads, but clearly it takes 3 to 5 years at least to break even before you can start to yield any returns, right? So there is need for a long-term concessionary agreement so that you can have adequate lending from banks and financial institutions to be able to back up some of these PPPs, because the capital costs involved are significant. The second one is clearly there needs to be investor protection norms which are standardized and put in place. Whether it is debt funding, even the IFC or the World Bank that needs to fund it, clearly they're going to need some kind of protection for either the debt providers or the equity investors to ensure that that happens, and that's long-term and in place. I think the third is clarity around the rates and reimbursement would certainly help. If we agree that CGHS is a good norm for us to use as a benchmark against which to peg a PPP, then I think ensuring that that clarity of policy comes through would certainly help. I think beyond this, the most important thing is really the dialogue for it to happen. And it's great to see people as progressive as Dr. Montesquieu in the morning, Dr. Vishwas Mehta and others, really progressive, inviting this conversation to happen. And I think, the road ahead looks much easier in that context.
No, I totally agree. I think the faster the dialogue starts, the faster we'll go through the roadblocks. Raju, one of the things, now more from a provider perspective, when you've gone into PPPs, from a practical point, what are some of those issues which you faced, going ahead, which you really feel, the government could look at? Because those could be areas, because we clearly see there is not too much of private sector participation. Even when RFP come out, you only have maybe 1 or 2 private providers coming in. So what are these 2 or 3 areas which really you think could be redressed and to make this much happen?
I'd go by what KK said, and let me just repeat it, because I think that the whole issue is in terms of the trust deficit that is there, and how do we bridge that? And I think KK has very nicely put these 3 points out in terms of having a proper concession framework. You have operating guidelines, having standard operating procedures, funding, and also in terms of payment. I think if you have that very structured, certainly I think there would be a lot more confidence, the way that there has been confidence in other industries, in terms of roads and things like that, where all this has been tried and tested, and I think it's now more like a cookie cutter. But the other point that I also wanted to bring up is what I think the concern that KK raised was in terms of affordability. In the process of doing this, are we going to compromise on the affordability factor? And I think there, the fact that there is actually a very good PPP going on, despite a certain amount of criticism on that, and which is the various government community insurance schemes that are coming in. So what I see here is that if you tie that with the government insurance schemes like RSBY or the Arogashri's schemes that are there, the government is actually controlling affordability. They are already controlling the price at which there is a reimbursement or price at which the procedure is to be done. Of course, there are misuses of that, and I think that's where the control has to be. How can you tightly control the misuse that is taking place? But if you address that separately, I think the framework is already there. And we just need to take learnings from some of the other things that we've done in other industries and replicate that within the healthcare industry.
Thank you. Paul, I think going ahead, obviously India has just got onto the path of healthcare PPPs. So, we don't have so many examples. How do you see PPP panning out globally? And, what could be some of those learnings as we go ahead we should be really aware of? Not to repeat the mistakes which have been done in the developed world.
Thanks. That's a simple question for me to answer. I'll look at my crystal ball and see what it tells me. But I think certainly everything that I see and hear when I talk to governments around emerging economies in particular is that they recognise that they need to do something different if they're going to improve their healthcare delivery of services, and they need to mobilise new skills, new capital to do that. So I think certainly more and more we will see PPPs being used to provide what are typically seen as public services in healthcare. And I say that because governments still need to be able to keep control either through regulatory regimes or through other mechanisms, keep control of how healthcare is delivered and the quality of healthcare, because ultimately that is a public good they have to manage. So I certainly see more and more governments doing that. I think in terms of learnings, I would add the things I would add to the points that have already been made are that for investors in particular, when you're looking at healthcare PPP projects, they are, and here I would disagree slightly with maybe some of the panel members, that they are different to other sectors. It's not a road, and I think whilst I recognise the need to somehow learn from previous projects, regurgitate that learning, make sure it's applied, and in some way standardise as much as you can. The variety of projects that I see around healthcare and around the world are so varied that actually applying a standardised approach is actually very difficult. But I think for some things you certainly can do that. But some of the simple things that I think the governments can do to help in this regard is to first of all recognise and invest in public sector capacity. So quite often what I see as one of the key failings is that the public sector either doesn't have the capacity to structure these projects in the first place and procure them in a sensible fashion, or it procures them but then doesn't have the capacity to measure, to monitor them and to evaluate them over the long term, and essentially absolves itself of all responsibility when the project's closed. And that I think does lead to some problems. The other point is really about if somewhere like India that I think from where I'm sitting has some of the most innovative projects going on right now. How do you disseminate that information? How do we learn from what's going on? And how do we then make sure that each state isn't reinventing the wheel each time they want to do a project? And I think there's definitely a role for either a national PPP unit or even, depending on the size of the states, state-level PPP units that can take responsibility not just for disseminating that information, but also setting policy direction and regulatory direction.
Thank you, Paul. So before we open it to the audience, another poll. Can we have the questions up? What's holding back PPPs in Indian healthcare? Can we have the slide? So I'll just read it out. So just when we were talking about technology. So the question is, what's holding back PPPs in Indian healthcare? And I'm going, it's up there. So lack of political will. So that's for the government. Acceptability of fair margins, clearly for the private sector. Trust deficit, that's for both of them. And finally, there's no uniform framework. So it's again A, B, C, D. and you have the choices. That's a good idea. Yeah, but then we thought it become too obvious, so we want to know which is most important among these four. So while we're doing that, why don't I open it up to the audience? So if you have a question, please stand up and please mention your name. Can we have the mics? We'll start with you, sir.
My name is Gunther. I've got a question in terms of the IFC. I was very interested about the Lesotho project. Two questions on that. Number one, did they make use of IFC funding? If yes, what was is it a term loan, and what are the interest rates? And what was the internal rate of return that they calculated the project on? And then just to comment, to hear governments being interested in PPPs, I wouldn't look for frameworks. If I was a private investor in healthcare in this country, I'd go to the government and show the government how you can save them money, not only on direct delivery, but in terms of the capital cost too. And I would not only pull in the Ministry of Health, I'd pull in the Ministry of Finance too. Thank you very much.
Yes.
I have got one comment to start with. You know what we are talking today since morning, we are not talking about increasing disease burden in this country. And increasing disease burden is due to increasing population in this country. In this country, nobody talks about population increase, how we are going to control it. Because those people who are really deprived, they are increasing the population. Those who can afford to increase the population, they are reducing the population. That's the big issue. Number one is nutrition, water, clean air, and nutrition. We didn't talk about it. Let's forget about it now. Let's come to the nitty-gritty public-private partnership in the primary health. You can provide money, you can provide this, but from where do you get the personnel to look after the whole thing? And very rightly, Dr. Vishwas Mehta said that in this country, this is a country of all the pluses and minuses. I come from a part of the country which is the most deprived area called Bihar. It has got many people will smile and laugh when they hear Bihar, because we have a population of 22 million. And we have how many medical colleges? 10 medical colleges. How many medical colleges? 11 million, I'm very sorry. 11 million. No, 110 million. 10.5 crore baat Hindi mein. About 10, 1 million. In third planning commission.
Right. So,
Mudaliar gave, just let me give, this is very important. Mudaliar gave that on 50 lakh population, there should be a medical college.
Can you just question,
focus
on the question? Because
there is a question and there is rebuttal also. Please do listen. We are sitting here not for sitting. Since morning I have been sitting here. You see, Mudaliar has given that on 50 lakh population, there should be a medical college. In third planning commission, if you take that way, we have enough medical colleges.
Right, sir.
Dr. Vishwas has rightly said, more medical colleges in one part and no medical college virtually in other part. In a place like Pondicherry, there are 9 medical colleges.
Sure, sir.
In Bihar, let me ask this. Who is responsible for this? It is said that regulatory bodies, who gives the essentiality certificate to start a medical college? The government of that state. They are not responsible for the people, they are not responsible for the country. And who ultimately gives the permission? It is the central government. So central government and state government, they are the ones who should first regulate the personnel. Because in a state like Bihar, whole population is going towards those what called so-called developed states, and they are staying back.
Thank you, sir. We'll park that and we'll take that offline.
Very important issue.
Sir, for better private-public participation, we have to give more importance for the private sector by making it as an infrastructure category. Only if we make it as an infrastructure category, it will become more affordable. Insurance companies are trying to squeeze the private sector by lowering the tariff and other things, whereas the expenditure is on increasing. So it is high time central union government declare the private hospitals as infrastructure category and allow us to enjoy the benefits of the that category, sir.
I think you're very right, and most of the healthcare bodies have been looking at, looking at healthcare as an infrastructure, and I'm sure that will happen. So,
I'm Dr. Akhil Sangal. I'm CEO of Indian Confederation for Healthcare Accreditation. My question to Mr. Rajan is saying about subsidized healthcare. Who pays the cost for the education? In your model, you were saying that you've taken 2 district hospitals where you provide affordable healthcare or highly subsidized healthcare. Who pays for the education?
The students.
The students. That is what I wanted to hear, because what we are actually producing today are the future EMI doctors, as I call them. Anybody who has paid ₹1 crore or spent that much is the first duty, like all our representatives, to recoup that money. And then we talk of professionalism and ethics. We are only talking of cost shifting. See, you're shifting cost from one place to the other, so you'll have the Ministry of HRD on your back saying that you are providing education now at exorbitant costs. The education is no longer affordable.
Let me answer that. You've touched on very, very important points, but the resolution and answers to that cannot be done over a short period of time. You have to take a couple of generations, the way that medical education has developed in our country. I do agree with you that today medical education, the hidden costs of it are fairly high because of the whole capitation issue which is there, but it arises from the fact that there is a demand-supply gap. Okay, and typical to any other industry, when you start increasing the supply, automatically the price of that education starts coming down, because people then now have a choice. And you have seen this happening even in the engineering education, where with the proliferation of engineering institutes, today you find that even engineering institutes are going begging. Seats there are going begging. So it is not something that we can tackle over the next 5 years, or maybe even 10 years, but if you have a long-term view in terms of addressing the whole demand-supply gap in the medical education sector, then I do believe that over a period of time, all that will even out. And yes, people do today say that I have spent X amount of money and I need to recover it, and therefore this whole ethical issue comes up. I do accept that this is a bane in this particular industry, but there are no short-term solutions. We have to look at it on a long-term basis, address the skill gap, address the education gaps which are there. And I do believe that over a period of time, we would be able to address all of this.
That's precisely what I was
Thank
saying,
you.
that in
Thank
terms
you.
of cost shifting, when we are
so
talking...
we could take this offline because we're running out of time. Can we have the poll results up there?
It's here in front of you.
Has it come on?
Trust deficit.
Right, so it's very clearly a trust deficit.
Lack of political will.
It's regarding public-private partnership. I have a direct question. Before that direct question, I compliment the public-private partnership. I'm from Reliance, Dr. Rajesh. We have 2 public-private partnership projects. One is Surat HIV/AIDS Center of 35 beds hospital, and second is Dahej. Both are running exceptionally well. Compliment to public-private. Now my direct question to the minister regarding NCDs prevention. In last 15 days, I have seen NCDs death in the range of 20 to 30. And one cannot believe one young doctor passed MBBS, completed internship, joined only 6 months ago, was having high cholesterol, triglyceride, came with severe, massive global ischemia, died. The thing is that whole scenario is changing. Now, if suppose some young entrepreneurs wants to enter the diagnostic centers in the cities in India, for public-private partnership, where they have to approach. That's the most difficult thing. And so many of my friends are asking where to approach for this public-private partnership for such setups in the various districts in India.
Answer is to me, a question is to me?
Yes, sir.
See, it's not for the ministry to decide that. See, he had already pointed out, Krishna Kumar had already mentioned, it's a state subject. If I am state health secretary, and if you come and say that there are 4 or 5 districts where I would like to set up diagnostic centers, I will say, yes, sure. And I'd like to discuss with you modalities. You will say this is the rate I will charge, and just like CGHS has decided, I will say this is the rate which we can, and perhaps we can reach a figure. I'll give one example to you. There are 5 government medical colleges. When I was Health Secretary Kerala, that was about 5-6 years ago. Dr. Sadullah is sitting here, my old friend that time, and we were working on several projects like this. None of the medical colleges had CT scans working. None of them had MRIs. In Calicut Medical College, I found to my surprise that we had the user fees, 1 rupee, 2 rupee, which we collect from the patients. Yeah. They had built up sufficient money to buy an MRI, and we allowed that. They bought on their own. The other 3 medical colleges in Kottayam, Alleppey, and Tichur, I approached not the private sector, because we don't have any with some few exceptions, we don't have industry, there's not so much of investment there. So what I did is I approached the public PSU, Hindustan Electrics Limited. I convinced them, and we set up three MRIs in these 3 medical colleges. We signed MOU to ensure that even if the government changes, officer changes, they are bound by that agreement. That MOU was signed. Will you believe what happened in that? In 5 years' time, in 3 to 4 years' time, not only the MRIs are functioning excellent, they have recovered their money because of the volumes of the patients, except Alleppey, which is taking more time. But the best part was that the rate of MRIs all over Kerala dropped because of this. The reason was we couldn't have managed our own. It's not that government doesn't have machineries, equipments or infrastructure resources. We would like to invest, but then our chaps will spoil it because of the commissions involved. So people were still recommending outside for commissions, but they couldn't spoil the machine. Then the rates were there, and the machines were inside the medical colleges. So there are areas where it can work. Only thing is, you can't recover this money in a fast track. It has to be long term. It is a long drawn out process. You have to go by volumes and not by rate of returns, which we keep talking about in business model. This is a little different ball game, The fact is, government will always be interested in what? They are not interested in profit. We are never interested in profit. We are only interested in whether the end result goes there efficiently, effectively, better than government can do or not. If you can ensure that, PPP will work.
Thank you. Thank you. I think we're running out of time. Sorry about that. So I think one of the very clear things is we're going to have a big dialogue on the public-private partnership, and maybe we've initiated that here. I'd like to thank all the panelists for their insights. I'd like to thank the audience for being so proactive. I think this is something we need to make it happen, because we're dealing with possibly the most valuable resource the country has, the health of over 1.2 billion citizens. Thank you.
Thank you very much, gentlemen. Ladies and gentlemen, we're not going to take a break. We're just going to go into the next session. So please be seated. Remember to keep your voting pads with you, because we will have the next session using the voting pads as well. So welcome to the 3rd plenary session. Please be seated, ladies and gentlemen. To the 3rd plenary session that examines talent, fast forward, upskill, upscale. And to set the context, we have with us the chairman of NIIT, Mr. Rajendra Pawar. If I could request you, gentlemen, to please be seated. Ladies and gentlemen, the chairman of NIIT, Mr. Rajendra Pawar. If I could request him to please come up on stage.
Hello.
Just wait for your video to run. Yeah.
5 to 7 minutes? Not at all.
We're having a little technical problem with the screen, so
We'll just give it a minute. I think they're wanting to get the videos to start, and I'll come in soon after.